Well, I'd like to extend a warm welcome to everyone joining us today, and those who may be watching this recording asynchronously. My name is Sandra Sujin Lee, and I'm the Chief of the Division of Ethics and Professor of Medical Humanities and Ethics here at Columbia University. It's really wonderful to see so many of you today in the third event of our Bioethics in Film from Screen to Seminar series. Through bioethics and film, we convene around films, documentaries, and television as useful tools for exploring critical, ethical, and social issues and questions that impact biomedical research and health. I'm especially excited by how many different specialties, disciplines, and fields of study that are represented on our panel and in our audience today. Leveraging multidisciplinarity and our collective expertise and experience helps us better understand and navigate bioethical challenges, and specifically the complex nature of our subject matter today. The film we have chosen, Aftershock, details the long-lasting effects of the Black maternal health crisis in the United States. Through the eyes of their surviving families, the film represents the legacies of expectant mothers, Shamini Gibson and Amber Rose Isaac, who tragically died due to the lack of adequate medical care. Promoting awareness and prompting change, the film follows the moving fight for health justice and asks medical professionals, what must you do to address preventable pregnancy-related death? It provides each of us an opportunity to consider what is our relationship to informed care, medical autonomy, and institutional accountability. To maximize time for discussion today, our series provides opportunities to view our films before the panel sessions. So for those of you who were able to view the film yesterday, we hope you can join the discussion by sharing your perspectives. But if you haven't had a chance to watch it yet, don't worry. Today's discussion will be completely accessible, even without prior knowledge of the film Aftershock. So we're fortunate to have wonderful panelists today, Doctors Danielle Laraque-Arena, Dána-Ain Davis, and Colleen P. Campbell. And we also have an expert moderator, Dr. Lisa Nathan. In today's program, you will hear from our moderator first, who will provide some opening remarks, and then we'll hear from each of our panelists, followed by moderated discussion. We warmly welcome you, our attendees, to join this discussion by sharing your questions in the Q&A box and any comments or observations you would like to provide in the chat box. Before I introduce our moderator, I just wanted to go over a few more housekeeping items. We first ask that all attendees please abide by the code of conduct, and you should be able to find a link to that code in the chat. We have a live closed captioner present for this event. So if you wish to use closed captioning, please turn on the CC button at the bottom of your screen. We will reserve the last half hour of this event for discussion. So again, we really encourage you to use that Q&A button that you find at the bottom of your screen and write in your questions for the panelists at any point during the session, and we'll keep track. You can register your enthusiasm for a question in that Q&A box by elevating it up the list by using the upvote button in the box. The chat box, again, is there for your further engagement. Please know that we will be posting relevant links to resources that are referenced in today's discussion there as well. A portion of today's presentations will be posted in the chat and will also be available on our website following the session. And finally, if you have any logistical questions or have troubleshooting needs, please email us at the email in the chat at any time. So now it's my absolute pleasure to introduce the moderator of today's discussion, Dr. Lisa Nathan. Dr. Nathan recently joined Columbia University as an associate professor of obstetrics and gynecology and is the chief of obstetrics at Sloan Hospital for Women in the Columbia University Irving Medical Center. Dr. Nathan has a passion for health equity and is a member of Columbia University's Anti-Racism Coalition, where she sits on the committee on addressing segregated care. Prior to joining Columbia University in 2022, Dr. Nathan was the medical director of labor and delivery at Montefiore Medical Center at Einstein College of Medicine in the Bronx. There, she founded the Global Women's Health Program for the department with grant support from the Einstein Global Health Center and the U.S. Fulbright African Regional Research Program. Dr. Nathan also founded Einstein's Departmental Health Equity Task Force. She also currently serves as the co-chair of the Maternal Mortality Review Committee at the New York City Department of Health. So with that, I'm very happy to hand it over to Dr. Nathan.
Thank you so much, Sandra, and good morning, everyone. If someone could please pull up my slides. Perfect. So I'm really thrilled to be here moderating this really important discussion today. And I thought I'd start us off today by remembering Erica and her father. So this is Erica Garner, and that is Eric Garner, her father, that you can see there at the bottom right. And for those who are unaware, Erica died after giving birth to her son. And in the work that I do, I've reviewed hundreds of maternal death cases at this point from New York City. And I chose to highlight Erica's death today because this was a young Black woman who was marching in the streets of New York, demanding justice for her father's wrongful death at the hands of the police. And then she herself died weeks after birthing her son. This family's tragedies are just really poignant of the crossroads of racial inequity that we're at in this country. And this family was assaulted on so many sides. And it's just heartbreaking to me as a physician that healthcare was actually one of them. Next slide, please. Now, there's some that think that only poor, uneducated, unhealthy Black women die in childbirth, but of course, this assumption could not be further from the truth. This is Dr. Shalon Irving, who you see here on the left, and that's her mother and her baby on the right. And she was a lieutenant commander in the U.S. Public Health Service Commission Corps and a very well-respected CDC epidemiologist who died at 36 in Atlanta, reportedly from complications of postpartum preeclampsia. This, despite the fact that she was highly educated, she worked at the CDC with some of the most well-known maternal mortality experts, and her focus was on health disparities research. So the question is, how does this happen and why does it happen? A death like Shalon's truly leaves many of us feeling like nothing can protect a Black woman from dying in pregnancy and childbirth. Next slide. So what do the data show us exactly? This data is from 2020, and I'm sure you're all very well aware of how poorly the US fares compared to other high-income countries, far surpassing them all. Next slide. This graph shows maternal mortality rates yearly since 2018, showing the exponential rise over time, and especially from 2020 to 2021. Importantly, it clearly displays the disparities by race and ethnicity, and I've circled here the Black non-Hispanic group. You can see that they die at rates multiple times that of non-Hispanic whites, which are just to the right, and Hispanic women to the far right. Next slide. And to put this in further perspective, the Black maternal mortality rate is nearly, as of 2021, is nearly 70 deaths per 100,000 live births. And I've listed some countries here to the right with some comparative maternal mortality rates. And what it shows is that Black women in the US in 2021 had rates of maternal death that's comparable to those countries like Libya, Brazil, Colombia, Algeria. It's just shocking. Next slide, please. So that was national data. This is New York State data, and it's very similar. I really like these slides because it shows the racial disparity in a slightly different light. So this data, again, is just of 2018 deaths only, and you can see the pregnancy-related deaths in the solid blue, and then the live births are in the blue hash bars, and these are by race and ethnicity. Next slide. And what you see here is that the data for Black non-Hispanic women, and what we see is that these women were way overrepresented in the pregnancy-related death cohort. Next slide. Given that the number of births to Black non-Hispanic women represented only 14.3% of all the live births in the state, while the deaths to these same group of women represented 51%, more than half of the pregnancy-related death cohort. Next slide. Now, this is in stark contrast to the births to white non-Hispanic women. This group gave birth to 48.2% of all the births in New York State, while their deaths were only 34% of the pregnancy-related death cohort. So again, this is state-level data, and as I had mentioned earlier, I work for the city, and this racial disparity is observed as well in city-level data. I don't have it for you today in a graph format, but I can tell you that the data here in the city, our Black mothers are giving birth to only 1/5 of all births, but they account, again, for half of all pregnancy-related deaths. Next slide. This slide is city-level data, and in this slide, you can see the Black-white disparity presented with the pregnancy-related maternal mortality ratio. This data is presented from 2001, and you can see that this ratio for Black mothers has ranged anywhere from 6 to more than 17 times higher than that same measure for white mothers. And on average, the ratio was 9.4 times higher for Black compared to white mothers over this time period. Next slide. Of course, all of this begs the question again of why. Now, in the past, we thought that these disparities were due to race. We thought they were biologically based, and we thought that race was an actual risk factor. But it's clear now that one of the biggest driving forces behind these huge racial inequities in maternal deaths is not race, of course, but rather racism. The differential access to power and resources that different racial groups have, such as income, generational wealth, access to healthy food and good healthcare, access to parks and public spaces. And at the same time, it's also due to the disproportionate overexposure of some groups to harmful conditions, such as environmental toxins, over-policing, disproportionate incarceration. All of these things contribute to a social determinants of someone's health and ultimately to pregnancy outcomes. Next slide. Because of the work I do reviewing maternal deaths for the City Department of Health, I'm often asked, of course, what is at the very bottom of this problem? Why are we not improving outcomes? And I think, just like everything else in the obstetric world, it's very complicated and there's no one answer to the question. It's very multifaceted. And that's why I really love this schematic because it really depicts all of the factors involved and how they all are interplayed. And this is from Elizabeth Howe's publication on this very topic. She's done groundbreaking work, as I'm sure many of you are aware, in investigating the Black maternal health crisis in this country, and also specifically here in New York City. Now, she talks about a few important factors. I'll try to do this justice, but just recognize, of course, that any one of these areas could be a whole presentation in and of itself. If you look at the blue boxes to start at the left, you see that patient factors and community and neighborhood factors, and we know that some of the driving force behind inequities in racism and discrimination has resulted in residential segregation, underinvestment in neighborhoods where the majority of residents are people of color, and there's terrible inequitable distribution of resources. And this affects these patient and community factors for sure, because together this leads to chronic stress and disease and results in increased rates of comorbidities in this patient population, which you see there in the middle, that peach sort of pink colored area. But this is only one piece of the puzzle, of course. The provider and the system factors, which are those bottom two blue boxes, are also hugely important. In Dr. Howe's work on the Black maternal health crisis, she found that white patients at what she coined low Black serving hospitals had the lowest rates of adjusted severe maternal morbidity, while Black patients at high Black serving hospitals had the highest rates. And she also found that both the Black and white patients who delivered in high Black serving hospitals had the highest risk of severe maternal morbidity after accounting for all patient characteristics. So these findings suggest that the quality of care at hospitals that disproportionately serve Blacks is lower than the quality at low Black serving hospitals. So the answer is that it isn't just patient factors, the community or residential segregation, which definitely play a big role in poor outcomes, but it's also the quality of care. It's provider factors, their skill set and experience, as well as the healthcare system factors, nurse-patient ratios on the labor floors, hospital resources, how much investment has been made in the hospital and the providers, access to care. Importantly, not just during pregnancy, but also as well in that critical postpartum period. So this was just a very brief introduction to this very complex topic that I'm going to now hand over to today's panelists to do a little bit more in-depth discussion on. I'd like to now, if we could pull up our other slide here, and I'm going to present our speakers for today. So Dr. Danielle Laraque-Arena is a prolific and internationally renowned pediatrician, board certified in general pediatrics and child abuse pediatrics, who has advanced maternal child health in underserved and disenfranchised communities, holding multiple leadership positions regionally, nationally, and internationally. Her scholarly work has made explicit the necessary link between the elimination of health disparities and the attainment of equity in the representation of diversity in the health professions. Her current portfolio includes maternal mortality, child rights, violence prevention, mental health, health disparities, and health equity. Dr. Dána-Ain Davis is a professor of urban studies at Queens College, CUNY, and the director of the Center for Study of Women and Society at the CUNY Graduate Center. She's the author of the award-winning book, Reproductive Injustice, Racism, Pregnancy, and Premature Birth. And then we have Dr. Colleen Campbell. She is an acting assistant professor of lawyering at NYU School of Law. Her research employs critical and interdisciplinary approaches to public health law, regulatory law, and reproductive justice. Her current projects examine obstetric violence, obstetric racism, and informed consent in reproductive care. She's also examining the disparate impact of food and drug law on women of color through the inadequate regulation of cosmetic skin lightening products. So with that, I'd like to now turn it over to Dr. Laraque-Arena.
Thank you so much, Dr. Nathan. And I want to begin by taking a few moments. First of all, thank you for reviewing in short measure where we stand today. So we are discussing in this week Black maternal health, although obviously we are commenting on systems issues that may affect all of us. So I want to first take a moment, having looked at this film, Aftershock, both a few weeks ago and again today. I want to take a moment to honor the women whose stories were described in this movie, their partners and fathers of the children who survived and their families, and to say their names: Shamani Makiba Gibson and Amber Rose Isaac, and their partners, Amari and Bruce. And I want you to take a moment, a deep breath, to actually reflect on what that means to a family to lose a family member, and to lose it in ways that were preventable. So I reviewed the movie to ground me, not only in the science of what Dr. Nathan has mentioned, but also to have the emotional content that we require of ourselves, of our trainees, of what we do in our research, and understand the implications of the work. So in the first story of Shamani, we know that she suffered a pulmonary embolism, which was fatal. And you hear the following words. You hear, it's preventable. You see that she is surrounded by family. And after she passed, you see the celebration of life that she did not get to lead with her family and her children. The question is posed in the discussion of what happened to her. Do we know how to care for each other? We hear from the families ignoring the patient, not listening, and the after effects, and we hear the word ethics. In the second story on Amber, we hear the words disbelief. We actually hear beforehand a context of their lives, which is the happiness that surrounded the family prior to this event. We talk about pregnancy glow, that this experience of pregnancy was one that was cherished by the family. And then we hear about Amber's symptoms that could have alerted her clinical team that she needed help. And we look at some lab results that perhaps should have cued the medical team that she was in trouble. Next slide, please. I have no conflicts, financial conflicts to disclose. I do want to mention that I chaired the governor's task force on maternal mortality and disparate outcomes a number of years ago. That's where I met Elizabeth Howell, and then the two of us formed the New York Academy of Medicine Women's Health Research and Wellbeing Work Group. Next slide, please. I know you know some of these data, so I'm going to go quickly, but I needed to go back to the point of, it's not even the beginning, but I needed to go back to slavery, because the way the bodies of Black women have been considered, and I am a Black woman, a mother, a grandmother, and have delivered 2 children and have seen the birth of one of my grandchildren, that we need to not forget history and the fact that women's bodies, Black women's bodies specifically, were begun to support an economic structure of racism. We fast forward to the 1930s, where the maternal mortality ratio, that is the number of deaths per 100,000, was about 1,000 per 100,000. And we definitely have seen a decrease in that. And you see from 1969 to 1998, a 68% decrease. But what you see from 2018 to today, and you saw that with the data that Dr. Nathan shared, that we have had persistent health disparities with the current number in 2021 of 69.9 per 100,000 for Black women, right? And that disparity, that health disparity, while we have had decreases prior and then increases since 1998, that health disparity has not gotten better. So it points us to both systems issues within our entire health system. And now if you see the bottom row of US overall, you see overall, we've not done better, right? From 2018 to 2021, we have had increases. The increase is most prominent, as has already been talked about, in Black women. But as a country, we are doing poorly. Next slide, please. And I want to emphasize this again, that we have learned from the time that I was trained in the 70s and 80s. Of course, it's not race. Of course, it's socioeconomic and justice issues that dominate the profile in healthcare. And we will come back to that. But we are a country that has not recognized health as a human right, and therefore have not put into place the policies and the structures and the resources that would attack this problem fundamentally. Next slide, please. In New York City, since this is where we are, when we look at this movie and we look at the loss of life and what was lost, not only in that life, but in all of the individuals that surrounded these individuals that make up the essence of our community and the essence of our society, that about 50 people die during pregnancy or birth within 1 year, and there are different definitions with WHO, et cetera. That we lose 50 individuals. 50 stories is the one we have seen. And about 60% are preventable. The word that we heard from the individuals who spoke, the family members who spoke in the film. Next slide, please. So what must we do to address? This is what we were asked to talk about. What must we do to address preventable pregnancy-related deaths? Okay, so I think awareness and action. So awareness is not sufficient, but it is necessary. So who am I? And I would like you in the audience. I see there are 90 participants, and I'm sorry I can't see you and we can't interact more. But the positional statement is important because we know that the system has been dominated by those who don't represent the people that in fact they serve. So I will share who I am. I'm a light Black woman born in Haiti. Most of my education has been here. And I already shared that on a personal level, I am a grandmother, I am a mother. And as a pediatrician, I actually was trained and delivered many women. And then I actually founded a teen tot clinic where I had the pleasure to understand the benefit of team science. I did not work alone in caring for my patients, either preconception or during the pregnancy, Prenatally, I cared as a pediatrician and saw families prenatally, and then postpartum with a continuous comprehensive system of care. I was honored to do that at Harlem Hospital, where I met people like Pat Loffman, who is a midwife, Janet Mitchell, an obstetrician gynecologist, a social worker, Jackie Ravenel, who taught me about psychosocial assessment and the importance of our own lived experience and our respect for individuals and for communities, and of course, to listen. So I ask you to ask yourselves, who are you and where are you? Where do you fit into this discussion of what do we do collectively? I think knowing history and epidemiology is critical. Many of us are in the sphere of public health and medicine, but we must know that our history to understand how society has been structured. And it has been structured around racism and disadvantage and power. And yes, white supremacy. Establishing the frame for action. Well, many of us are academicians. I admit to being one. But do we take a framework of science that must prove over and over again what is evident? Or do we take a justice perspective, as Vanessa Northridge Campbell has asked us to take? Or do we do both so that we advance not just a repetition of the data that we know and we have lived, but that we then apply a justice framework to action that must resolve these problems in our lifetime? We must move beyond talk. Next slide, please. Look, I am a sister in all the senses of the word. I have two brothers. I had no sisters, biologic sisters growing up, but I consider all women my sisters. I did do a brief review of the PubMed literature to see keywords on maternal death and role of fathers. I only found 62 results. We have not included our brothers in the discussions about fatherhood, parenthood, and what happens. And I just cite a few of the articles. Of the 62, only 7 dealt directly with the impact of maternal death on fathers. How is that possible? How is that possible? Think of your own relationships. Is that a close member of your family, your partner died, that you are totally ignored by the healthcare system, not by community, which is reflected in the movie. So the titles of Fathers Matter, overlooked and underserved, understudied and under-researched. And while we're not going to have the time to discuss research, the lack of funding in research is critical to why we are where we are. And we must make a fundamental change in that. And families matter. And of course, Black families and Black lives matter. Next slide, please. There are systems that are more socially accountable in our educational process, where we co-define what the problem is. Since when should we, as physicians, doctoral level folks, masters, whatever our profession, be the only ones to define a problem? We must co-define that with those we serve so that we ask the right questions. And we must do that repeatedly in an iterative fashion until we get to the answers that have the ultimate outcome, which is an elimination of health disparities, an improvement of health for everyone. Let us not fight each other. I don't have time to discuss this. But as we say, well, if you improve this group, will you not focus on this group? No, those are false dichotomies. The discussion here is, how do we improve our entire system to be focused on justice and to apply the technologies of the 21st century? Next slide, please. So apply the evidence. I was interested, you remember CMMI, Center for Medicaid and Medicare Innovation results. There was a study on Start for Mothers and Newborn Initiatives, okay? 3 models of care were tested that each allowed incorporation of midwives, community-based workers, doulas, and community health workers. We know the data. We know internationally, globally, what models have worked, but we did test them 2013 to 2017. And I'll summarize very quickly. None of these models were shown to systematically result in worse outcomes or higher costs than a control group of similar pregnancies not participating in these models. 2 models were actually found, the ones with midwives, were found to improve health outcomes and lowering costs. So it's not that we don't know the answers to our system, our problems, it's that we have not chosen to implement those results at a national level and at a local level, in full partnership with the individuals we serve in communities. Next slide, please. So here, building trust, what does it mean to build trust? Well, listen, communicate, show respect, and we know how to scale. So once we have these innovative models, if we don't scale them to make them sustainable, we have not fundamentally changed the system. So horizontally, you apply to the next unit. You look at depth, adding existing innovations, and I don't have the time to discuss that, but they're real innovative models of centering care. And you heard a little bit about this different models. So do I deliver at home? Do I deliver in a birthing center? Do I deliver in hospitals? How has our system of care been organized to lead outcomes that are standardized across all of those choices by birthing individuals, and vertical adoption in different jurisdictions? And we'll have the benefit of hearing from our other panelists who discuss systems issues and policy. Next slide, please. So institutional societal accountability, we are all accountable. We have innovative models of care that we have not scaled up, we haven't implemented. We certainly need to use research to evaluate effectiveness in the improvement of outcomes, scale up, and continue to evolve, learn from others. But I would say to you, we need a full system shift to be able to get the outcomes that we are speaking about and that we heard so eloquently in the families that have experienced the worst possible outcomes, right? The loss of an individual that you love. And next slide, and I believe that's my last slide, please. What we must do. Yeah, you've heard it all. We definitely need to decolonize care and understand our history of racism and of slavery in this country and around the world, but that we have sustained those systems while claiming that we are the democracy of the world. We must use medical interventions appropriately, though. We are in the 21st century, so let's not forget technology, but understand the medicalization of maternal care and its impact. And a lot of it, and you heard the two women in the movie, both had C-sections, which carry worse outcomes, higher risk. We must understand that and understand when to apply technology and surgical intervention and when it is inappropriate and destructive. Of course, we must dismantle structural racism. At the very top, though, when we say quality of care for maternal care, we must look upstream and not blame those hospitals that in fact have been trying to do. I was at Harlem Hospital. HH is doing work to be able to support those who are in fact segregated care supported by Medicaid, right? And we must look upstream to the systems that have underinvested in our communities and underinvested in the hospitals. And again, I could go on. Address general perceptions of roles. We have gendered so many things. The fathers who show us so eloquently that they care for their children and they support them. I think of my own brothers who have done so as well. We must establish health and healthcare as a human right, as a basic thing, and we must regain our humanity and talk to each other. And here I have the pleasure of handing it over to my colleague, Dr. Dána-Ain Davis. Thank you.
Thank you so much. I want to thank both Dr. Lisa Nathan and Dr. Laraque-Arena for providing us with such a fantastic discussion, statistical analysis, philosophical perspective on how we need to be addressing these issues. I thank the organizers for inviting me to participate, and I'm delighted to be in dialogue with all of you. I want you to know that I enter this conversation as a person who has actively been working with reproductive justice for over 30 years. I enter this conversation as someone who's given birth, as someone who is also a grandmother. I enter this conversation as an anthropologist and as a doula. Slide, please. In my book, Reproductive Injustice, Racism, Pregnancy, and Premature Birth, I highlight how medical racism shapes Black women's prenatal care, labor, birthing, and postpartum services in the United States. I spent time with mothers, fathers, nurses, OBGYNs, the administration of of various organizations, midwives, doulas, to understand what the experience was like of the medical encounters that people had when they were in hospital settings. Within the context of maternal health risk and prematurity, I argue that the American medical system forces Black women to participate in a limited array of interventions that are informed by theories of wellness that actually ignore racism as the primary factor, in this case, birthing prematurely, and for those who have low birth weight infants. Aware of the medical system's limitations, the women in my study, and I say women because that is how everyone identified, describe the conditions under which they want to experience pregnancy, birth, and early postnatal life. I incorporate their stories with the perspectives of medical providers, many of whom refuse to discuss or theorize racism, and with the work of activists who have adopted what I thought of as radical strategies to support birthing Black people and their babies beyond the medical complex. Grounded in histories of Black maternal health and infant wellness, the analysis in the book describes how Black maternity is haunted by the afterlife of slavery. This haunting is not figurative nor metaphoric. Rather, it manifests in the refusal, actually, to name medical racism as a threat to Black life and the cause of Black death. After publication of Reproductive Injustice, I developed a framework, obstetric racism, to explain what some Black women and birthing people encounter and are subjected to at medical institutions. Elements of the book coalesced into this framework, showing that reproductive, gynecological, and obstetric services were woven together with the threads of history, as so eloquently been pointed out earlier, that have primarily valued Black women and people for their experimental potential as well as for capital gain. The degree to which healthcare infrastructure is built on institutional relations of power and violence is uncovered when one explores the logics of racial domination asserted on Black women and birthing people at any point in their reproductive lives. And obstetric racism rests on the fact that those racial hierarchies have led to differential practices, tasks, and clinical decisions. Slide, please. So obstetric racism, what is it? Obstetric racism is comprised of beliefs and practices leveled against the reproducing Black body that sits at the intersection of obstetric violence and medical racism. It is the mechanism of subordination to which Black women and people's reproduction are subjected that track along histories of anti-Black racism based on ideas of difference that have been worked out through the hierarchization of humanity and is contemporarily experienced as a remnant of the afterlife of slavery and racial science. The framework highlights forms of violence and abuse that medical personnel and institutions routinely perpetrate against Black women and birthing people during infertility, preconception, conception, pregnancy, childbirth, and postpartum, because they are Black. And what is important in understanding obstetric racism is that Black women, birthing people, and members of their community interpret their treatment as racism. Next slide, please. In unpacking the film Aftershock, I want to call your attention to some of the comments that I think help to establish and illustrate obstetric racism. Some of the comments were they kept asking if she were taking drugs. This is Sharmini's mother. Who are we, who we are, and what we look like is what Omari talks about, and that has an impact on how we're treated. They don't care. This is a person who was in the father's group. Mustafa Shabazz made this comment. They said that it was pregnancy-related issues. This is Amber Rose's partner, Bruce. If you are Black, you are less likely to get support for a vaginal birth. This is a comment by Helena Grant, who's a midwife at NYU. There was negligence and incompetence. Next slide, please. I want to just try to link some of the comments from the film and some examples that show up in the film to the dimensions of obstetric racism. There are 6 dimensions of obstetric racism, which you can see on the slide, but I want to point out that it's a flexible framework and additional dimensions may emerge. I will describe each one of the dimensions of obstetric racism, although not all of them are evident in the film. To be clear, while one may apply a dimension to a particular event, an event may be characterized by more than one dimension. But just before describing each dimension, I want to linger for a moment on the cast of people that are illustrated in this image. The people who represent all manner of hospital employees. And I thought this was important given that in the film, Amber's partner noted the way in which she felt dismissed, not necessarily or only by doctors, but by other people. So in this image, we see images of security, administrative assistants, nurses, orderlies, doctors, surgeons, etc. Next slide, please. So these are some of the components of obstetric racism. The first is diagnostic lapses, and this occurs when clinicians have an uninterrogated belief that Blackness is pathological, leading them to de-emphasize, exaggerate, or ignore a patient's symptoms, resulting in inappropriate or what I call lapsed diagnosis. In the film, Shemoya's mother described being asked time and again if her daughter were on drugs. Such a dystopic diagnosis reveals an underlying set of beliefs about Black behavior rather than believing Black agony, hurt, and pain. Neglect, dismissiveness, or disrespect is another aspect of obstetric racism. Both women in the film experience neglect and dismissiveness given the constant requests to attend to Amber and Shemoya's escalating medical conditions went unattended. This is not new. One might recall that in recent history in the 1970s, the negative consequences of Norplant implants, for example, on Black women's health were dismissed. They, in fact, were overlooked. And while policymakers viewed Norplant as a way to control Black and poor people's reproduction, many also noted its undesirable and unbearable side effects, which included headaches, vaginal bleeding, nausea, dizziness, and weight gain. However, the effectiveness of reducing pregnancy overshadowed those adverse outcomes. Next slide, please. Intentionally causing pain occurs when medical professionals fail to appropriately manage pain. As rightly described in the film, this failure is rooted in a centuries-old racialized belief about pain immunity, as well as an absence of empathy to reduce Black suffering. Coercion occurs when medical professionals perform procedures without consent and or intimidate patients to make decisions. And we hardly need reminding of the history of Black women being, quote, forced to engage in various forms of reproductive control in order to receive, say, welfare benefits. In terms of labor and birthing, coerciveness frequently comes in the form of being told that C-sections are necessary. This is something that I have witnessed actually a number of times as a doula, where people have been told that if they don't have a C-section, their child will die. Next slide, please. Ceremonies of degradation are the ritualistic ways in which patients are humiliated or shamed, and this also includes being sized up to determine the worthiness of the patient or their support persons, who may also be viewed as a threat. In the film, during the men's support group, Mustafa Shabazz noted that he was asked to take a DNA test before being allowed to take home his son. This demand was not only frustrating given that his partner had died, but it was also degrading. Medical abuse occurs when medical professionals engage in experimentation and or repetitive behavior that is motivated not by concern for the patient, but actually serves to validate the clinician's self-worth and upholds their domination over the patient. Obstetric racism reveals links between contemporary medical mistreatment and histories of medical racism over time, whether in the distant or recent past. Amber and Shemoya's experiences of obstetric racism may be read alongside the grains of history, showing how the racial dynamics within the medical complex exacerbate vulnerabilities. As with all forms of racism, obstetric racism exposes the various registers at which Black reproductive bodies endure mistreatment. And the origin of this mistreatment is wrapped up in histories of racial science, medicine's dependence on derogatory ideas from the past that have migrated to the present, and the projection of representational repertoires and stereotypes. While it is important to center racism in our thinking about reproduction and reproductive health, we must absolutely also acknowledge the strategies used to address them. For instance, increasing the number of birthing centers, ensuring access to group prenatal care, developing comprehensive systems of care that are not necessarily medical-based when medically based interventions are actually not necessary. We must also remember that individually, Black women themselves respond to obstetric racism through several strategies. One is what I've called racial reconnaissance, which describes the almost Herculean effort made by Black women to avoid or mitigate racist encounters, including being hypervigilant about procedures and hypervigilant about finding providers that will be responsive to them. Refusal. This is a circumstance where one does not consent to participate in the medicalization of their birthing. They deploy instead their own will against the system of control and the demands of consent. Refusal in this case is informed by a clear sense that one rejects the possibility of coercion, medical intervention, abuse, disrespect, and the power that is sometimes used to dominate people. It goes beyond people understanding the implications of not doing something, but rather they understand and are concerned about agreeing to do something. Finally, there's resistance. Resistance is a strategy whereby a person uses the knowledge that they have to push back against the mandates or requirements to intervene. It is an act of mobilization against a system, and it can involve questioning the terms of intervention and negotiating various forms of involvement in decision-making. It is rooted in having a vision of how one wants to be treated based on their own terms. As always, I leave us with a question to ponder, and that is, how do we radically transform the systems, practices, and procedures to meet the needs that Black women and Black birthing people have? Slide, please. Thank you so much for listening, and I am delighted to turn this over to Colleen Campbell.
Thank you so much, Dana. It's a pleasure to be here this afternoon. So before I begin, I'd just like to thank the organizers of this event and the filmmakers. And I'd like to pay my respects to the families who were featured in the film, and just express my gratitude for giving voice to those women who are no longer with us. And I appreciate the presentations that have gone before me, because they highlight some of the issues that will come up in my discussion as well. And I'll just begin. So the topic of my presentation is the biopolitics of obstetrics, and I wanted to explicitly address some of the bioethical issues that came from the film that are also important issues in this context. The starting point of my discussion is the bioethics of informed consent, which is an important principle in medical decision-making that prioritizes patient autonomy and freedom of choice. Scholars at the intersection of race and medical ethics have argued, however, that issues like agency, medical agency, and autonomy are constrained and affected by institutional, legal, structural, and historical forces. So agency should be something that is understood as structurally produced. In obstetrics in particular, the issue of birth choice, a decision of if, how, and where to give birth, this is also affected by all of these institutional concerns. So a biopolitical framework necessarily adopts a critical race feminist and a reproductive justice lens that centers Black women's experiences and perspectives. In terms of obstetrics, I think it's important, some of the issues that I'll raise here have already been identified, but obstetrics is a uniquely gendered, very gendered space. And so there's a theorization of obstetric violence as systemic gender-based mistreatment in childbirth, which raises a lot of bioethical and biopolitical issues in terms of medical decision-making. And obstetric violence is fueled by a lot of institutional forces, such as fetocentrism in the law. And this is the increase in prioritization of the interests of fetuses against those of mothers. And you see it not just in obstetrics, but in reproduction across the board, where women are criminalized or subjected to coerced obstetrics or coerced interventions because of this logic. As my colleagues have mentioned, the issue of access in non-medicalized birth, and in particular in the United States, the criminalization of midwifery and the barriers that we've erected to prevent entry into the profession or limit entry to the profession also limits access to non-medicalized birth or alternatives to the dominant model that we have. Additionally, the malpractice environment where fear of litigation also filters into treatment recommendations. And that's where we see a lot of hospital VBAC bans that categorically limit people's options in terms of vaginal births after a cesarean section. There's also the criminalization of reproduction across the board, which, especially for women of color, has been used to control their reproduction, which scholars have talked about. Now, in the film, the VBAC calculator was discussed in the context of race-based medicine, which I think is an important issue, especially in the algorithm context. But if we take a step back, I think it's important to think about the bioethical issues associated with the calculator. So it's certainly a tool for clinical management that's become routinized, but insofar as it's been used as a dispositive tool, so insofar as it cuts off conversations about other alternatives or the risks that are associated with a repeat C-section, for example, it undermines women's preferences and their informed consent. So it also ignores other systemic factors that may determine a successful vaginal birth after a C-section, such as the quality of hospital post-operative care. So, if an institution is anti-VBAC, then that's going to affect the support that birthing people have for VBACs and the success, the rate of success for VBACs. Additionally, it prioritizes patients' bodies, such as body mass index, and instead of all of the systemic issues that affect rates of VBACs. And lastly, it prioritizes relative versus absolute risk, because the absolute risk of a uterine tear is actually small. And so these are some of the ethical issues that are associated with the VBAC calculator. From our critical race perspective and a critical race feminist perspective, as Dana has mentioned, the calculator should also be understood as a tool for obstetric racism, insofar as it naturalizes racial differences through biological race, and it conducts a sort of surveillance of Blackness. And it's important to note that this is something that transcends obstetrics, because we see other algorithms in other medical contexts, like these tests for kidney function that actually attribute different values to Black folks, the EGFR test, I believe it's called. And so biological race, in this sense, operates as a means of dehumanizing Black women and Black people within medicine and science. From a biopolitical perspective, and this is why it's important, it ignores, in this context, it ignores how racism might have structured successful VBAC in the first place. So the creators of the calculator took a snapshot in time and determined that Black women were half as likely to have a successful VBAC as white women. And so they used this data to create a calculator that actually reproduced the same racist status quo that they observed. And it also, the logic that the creators derived from the status quo was that it was something innately about Black women's inability to have successful VBACs. And that's been the problem with the use of the calculator in terms of its biological connotations, as opposed to the alternative way to think about it would have been hospital culture and racism were probably more significant predictors of successful VBAC rates than even patient physical characteristics. So to the extent that it's been used to block Black women's options and preferences regarding having vaginal birth after a C-section, then it certainly undermines their medical agency and their decision making. In terms of the new VBAC calculator, there are similar critiques that should be identified here. So if it assumes, and it does assume, that primary C-sections were medically necessary, then that means that for Black women who have higher rates of C-sections and also higher rates of medically unnecessary C-section, they're still going to be more likely to be entered into the new VBAC calculator. And I think that that's important. That's an important issue that should be brought to the conversation. So racism is still influencing this issue, and it also is incorporated indirectly through other socially determined variables like body mass index and chronic hypertension. And so I think that there are still issues in terms of how the existing calculators are used, and if physicians are not talking about the risk of repeat C-sections, for example, or even other limitations of the calculator in terms of accuracy, predictive accuracy at certain levels, I think that also affects patients' decision making and the issue of informed consent. And I can talk more about that later. So if agency is something that's structurally produced, then it can be influenced, right? So if it's not just something that's exercised individually, we can think of it as something that's collectively exercised, or there are ways that we can shore up Black women's medical agency. And as my colleagues have talked about, having access to support services like doulas, which improve not only birth outcomes, but they reduce C-sections. This is because, if you're a young Black woman who goes into a hospital with a high C-section rate, chances are, even if you're healthy and don't have serious risk factors, chances are you're going to come out with a C-section, even if your birth plan is to have a vaginal birth. But if you have a doula, that will probably help you. That might be the decisive factor that helps you to have your birth plan honored. Unfortunately, a lot of states don't provide Medicaid coverage for doulas, and there's been a low uptake due to low reimbursement rates. In terms of a paradigm shift, which has been mentioned just now, I think that the United States, one of the things that stands out with the United States is that it's marginalized midwifery, which is a long historical process. And so I think there has to be a centering of midwifery specifically in this discourse, because that also is important in terms of patients' preferences being honored, and it's also the case that birth outcomes are the same or better for low-risk pregnancies with competent midwives. But we also need to center Black midwives to improve concordant care. Unfortunately, in this country, right, both the patient and provider population for midwifery are predominantly white and privileged. And so, and I mentioned, I mentioned this country I come from, Jamaica, and I was, I come from rural Jamaica, although I've lived in the US since I was a child, but I was delivered by a midwife, a community midwife, and it was normal for rural folks, poor rural folks to use midwifery. It wasn't something that was exceptional or prohibitively costly or anything, but that's not the model that we have in the United States. And it seems really, I mean, there's a lot of scaremongering that has happened with the conversation about, home births and midwifery that comes from institutional politics. We definitely have to talk about abolishing the barriers to the profession, and also reframing the anti-midwifery politics and laws that we have in this country as an ongoing assault on Black women's maternal health. And I'm wrapping up now. So the last thing I'll discuss is the issue of cultural humility and recognizing Black women's bodily expertise. As we've seen, it can be an issue of life and death, right? And I'm bringing up Serena Williams here because she called herself Dr. Williams. She basically diagnosed herself because she said, I know it, I know my body. And it just takes a little bit of humility to listen to patients. And for Black women, it goes a long way. And so I think that that's another paradigm shift that has to happen in medicine. And that's just a slide relating to connecting the history of abortion bans in this country to midwifery and trying to make the connections. But I'll end there. Thank you.
Great. Thank you all so much for a wonderful discussion. I'd like to just start us off now with some discussion questions. I'm going to actually ask you, Dr. Campbell, if you can address one of our questions that's been put in the Q&A, where one of our participants has asked if any lawsuits have been filed against practitioners of obstetric racism and what were the results.
I am not aware of any lawsuits on the basis of obstetric racism. And so I don't know if it's, I'll pass it over to Dr. Davis, because I know you've been doing some work with the Birth Rights Bar Association on that.
Yeah. So there have been no lawsuits, but there was a memo that was sent to the Office of Civil Rights about, it was a memo so that people could file claims of obstetric racism and obstetric violence. And that memo was rooted in the fact that I think it's code 1577 of OCR suggests that any person who experiences any form of discrimination when receiving funds from the federal government could conceivably make a claim. And the point that many of us were making when we helped develop this memo was that people should be able to file these claims online through the online system. Several claims have in fact been filed. Of course, OCR has rejected them, but that does not mean that we should not continue to attempt to file claims of medical racism and obstetric racism, or rather, I'm sorry, obstetric violence and obstetric racism. I think obstetric violence is might be a slightly more complicated thing to file because it is in fact rooted in a human rights framework that has been dependent upon other countries having signed human rights treaties, none of which the United States has done, or signed rather.
To that point, thank you. In terms of the obstetric violence, my understanding is in the case of Renat Dre versus Staten Island University Hospital, she attempted to include a violation of human rights and other claims related to her experience of obstetric violence, and it was dismissed at the highest level. And so it hasn't, it's not something that's legally as accessible in terms of the medical malpractice context.
Dr. Davis, I see your hand is up. Did you have anything
Oh,
additional?
no, I meant to lower it. Sorry.
No problem, no problem. So I was just curious, I know we've all touched on this to a certain degree, but really asking that question of what mechanisms are in place that allow white women to have such high survival rates during birth, and what has prevented us from making the necessary changes to have those same mechanisms in place for Black women. It's a huge question, I know.
Well, maybe I'll touch on it and hopefully my colleagues will join. I mean, I think what's required is a full system diagnostic in terms of where we are. So if you look at the desegregation of hospitals, okay, and we're focused on hospitals, although there are other complex issues with respect to midwives and the system of care we've adopted. It's only in my lifetime, right, in the 60s with LBJ, that there was the desegregation of hospitals based on the premise that if you receive federal funds, you cannot segregate by race. So in my lifetime, that has happened. We have not, and, you know, our current system of not having universal health care means that we've dismissed the notion that healthcare is a right. And I think my colleagues, Campbell and Davis, just referenced it, that there isn't a framework of human rights. If you do that, if you don't adopt that premise of human rights, then it's very hard to structure a system that then dismantles the structure that was built into that, which was based on racism. So it's a complicated question that you ask. It's a complicated answer. But there have been steps to try to provide access during the COVID pandemic, for example. We know that we had automatic enrollment, right, for Medicaid, Medicare. I'm sorry, Medicaid. So because we know that there is a system that promotes that people need to actively re-enroll or else they fall off the rolls, even if they're eligible. So the more complex you make a system, to have people not automatically be part of a system that provides them access, not only to care, but to quality care at all levels, you have complicated the system so that it bars individuals from accessing it equitably. People like Bruce Vladeck, who was a former head of HCFA, which is now CMS, said it very eloquently that we refuse to adopt the systems that simplify access to care and standardizes care across the way. And then we're surprised at the outcome. We're surprised that it makes a difference. So I don't know if that begins to answer it, but we have not bought on to a universal system that then looks at the structures that are built in at upstream and downstream that disadvantage already disenfranchised communities. So what's the solution? You want solutions. I say that what is happening in this film for communities and individuals, women like ourselves, Black women, to speak up and to claim that power, to claim that voice, to move forward, to utilize the expertise of Dr. Campbell as an attorney and an academician, to understand how you shift that system to a justice lens, okay? And not just a scientific lens, to a justice lens, and to figure out the mechanisms to be able to dismantle that system that is so ingrained. So I could go on, but I'll stop there and ask my colleagues.
So I'll go. So I think that I'm going to be very cynical here. I think that cynical, but also probably reiterating some of what Dr. Laraque-Arena just mentioned. So I think that we've been framing a lot of these issues. We've been framing it as a data problem or informational problem. And so we spend a lot of resources trying to find more data. And often that means data about what's wrong with Black bodies. And so what is wrong with these women? How can we fix their bodies? Instead of actually trying to adopt interventions that actually might work. And so we could, for example, look at what California is doing. So if California's rates are comparable to Europe versus states in the South, for example, that indicates that we have some information about things that could actually work, but there's just no political will consistently across this country. And so in terms of, I think that in terms of the political will, there's a senator from Louisiana last year who was saying, look, we don't have really a problem because, if you disaggregate by race, our maternal mortality rate is just fine. So this is just really, an issue for people of color and Black folks. So we need to figure out what's wrong with them and to deal with it. So we don't really have a maternal mortality problem. So is it a surprise that Louisiana's rates are so dismal and probably look more like developing countries' rates? And so there's a crisis of political will. And unfortunately, we spend a lot of time focusing on the data gathering. In terms of the cynical issue that I was thinking about, we address these crises whenever it becomes this like national disgrace and international attention is start being drawn to it. The same thing is that was happening in terms of the police violence and now in this context. And so, I think that also speaks to where our convictions are. And I'll pass it to Dr. Davis.
Dr. Davis, you're still on mute.
I do think that, thank you. I do think that we engage in lots of data gathering, and I do think that that's important, but I also think that it's really important to incorporate community in naming and identifying what the circumstances and problems are, and also creating a kind of accountability at the institutional medical level. I know I talked a lot about doctors, but quite frankly, I feel like it's not, I think sort of blaming medical professionals actually is low-hanging fruit. I think it's an institutional issue that needs to be addressed through issues of quality improvement, quality implementation. And that one of the ways within a hospital system, and one of the ways that we can do that is possibly by maybe gathering data where hospitals understand how people experience racism in the hospitals where they are receiving services. And that is where the work of, I think, Dr. Karen Scott, who's an epidemiologist and OBGYN, where her work comes in, because she created a PREM-OB scale of obstetric racism, a patient-reported experience measure that can be utilized by hospitals to determine what the degree to which people feel that they've experienced racism. And the thing that's so unique about this scale is that it is the only validated scale literally in the world that documents racism that was created, that's rooted in a Black woman's perspective or theoretical framework, mine, obstetric racism, that was created by a Black woman, Dr. Scott, and that depended on Black women in community in the development of what some of the domains are where people experience racism in hospitals, such as kinship issues, care issues, being separated from family. So those are some of the things, some of the things that I think need to happen. Yeah, I'll leave it at that because I see there are other.
If I can add something, I do think that there are models, and thank you for mentioning the California experience, but I do think there are models that have shown, innovative models that have shown that we can do better. And so, not to end on a negative note, is to say, why don't we scale those up? Why don't we understand in the scientific, arena, understand that and really push for those models to be scaled up and to be continuously evaluated? I do think the work at the, most of my work has been at the hospital linked to communities, but quality improvement and PDSA cycles and repeatedly looking scales that reflect the kinds of issues that we've talked about in terms of obstetric racism. And thank you so much for discussing that. I think it really, I'm going to distribute that and incorporate that in my future discussions. How do we do that, encapsulate it, and continuously learn how to do better? Okay. there are political realities that have precluded us from addressing key issues, not just here, but for many other things. But doesn't mean we give up to partner with communities, partner with families, and then move that agenda forward. And I am encouraged by having an attorney here. My disclaimer is I have a son who is a civil rights attorney, so thank you so much for elucidating the avenues we might use to fight for justice, because that has to be coupled with our understanding of what's happening, in a healthcare system and why those things cannot continue. And so how do we shift that? How do we create that impetus for real fundamental change?
So one of the, in addressing this, what we're talking about, like other models, birthing centers, of course, was something that was highlighted in the movie. And one of our attendees put a comment and question into the Q&A box, saying that in the movie, they highlight Tulsa as having the highest maternal mortality rate, and people are turning to birthing centers as a way of avoiding hospital deliveries. Hearing that the cost of a birthing center is not being covered by health insurance, does this not seem like a feasible, solution for most people? And so should there be some lobbying, or what else can we do to get this covered by insurance and actually make it more accessible to more people?
Well, maybe I'll
go ahead,
Dr. Davis, please go.
No, I was just looking for the question, because for some reason it went out a little bit. Is this the Mary Bresnahan question?
The one, right? It disappeared. I think it went answered.
Oh, okay.
The anonymous attendee under the answered group.
Oh, all right. I'll see if I can.
If we could just maybe have a little discussion about birthing centers, if anyone has any experience or thoughts on birthing centers as an additional option, just that the cost, sometimes out-of-pocket cost, can be so prohibitive.
I mean, one thing I can say is that, birthing centers experience a lot of pushback, because what they're going to do is siphon off, ostensibly, they could siphon off funds from hospitals. It is so difficult to get all of the permissions for a birthing center in New York. It is, I have been on calls with, there's a group that's attempting to get the birthing center in the Bronx as described in the film. And the conversations about basically the walls that prevent people from getting birthing center is really it's really, really remarkable. And it's not remarkable, I think, when you think about the history of birthing centers and who wants to be in them and operate them. But there was a situation, for example, in the state of, I think it was Alabama, where there was an attempt to open up a birthing center. And then the Alabama legislature actually, maybe you can help me out with this, Colleen, the Alabama legislature then put up all of these roadblocks just before the approval for the birthing center was going to go up. I think that we need more of them. And the honest truth is that both birthing centers, midwifery models of care, et cetera, have been shown, as Danielle pointed out, have been shown to have really terrific outcomes. And even in countries where racism is rampant, like Germany and Cuba, the birth outcomes are better, partly because there is actually a belief in public health, and because there are midwifery models of care, birthing centers, and what they call birthing houses or houses, where people are able to have basically non-medical intervention if it is not necessary, if it's not deemed necessary. So that report that you referred to, there are several statements in there, because I've read it. I was fascinated, where it says, yes, we know these models are better. Yes, we know that the outcomes are going to, there's a 3% decrease in people. I'm sort of giving the numbers, in people having premature births. There's Black women in particular, there's a 4% decrease in all of these other outcomes. And then there's a line that says, but we know this will not become the dominant model of care in the United States. Ever. So that suggests to me that there's a bit of a collusion. And I think some of it has to do with reimbursements and insurance. A lot of it has to do with reimbursements and our model of managed care.
I know that there are discussions both, obviously at the state level, the city level, and nationally. I know that Vice President Harris began discussions around maternal mortality and Black maternal mortality. I think it's going to take those continued discussions to look at how care is financed, right? Because that's going to be a major driver of change, because hospitals, there is not sufficient obstetrician and gynecologists. They're not sufficient midwives. We don't have a system of care that's coordinated at the national level to really track outcomes. So I think it's going to take, and I can list some of the things. We've talked about the discussions around social determinants. We've talked about the perinatal workforce, right? How do we build the workforce? We can't say go to a midwife if you can't find a midwife, right? So how do we build our educational system to support that? How do we integrate a number of things that need to be part of a system of care to allow continuity? I know there was a question there that said, do we have a continuum of care in terms of being able to follow birthing individuals, women who have given birth, because you can certainly have maternal deaths, in the first 42 days or within the year. How do we address a system that actually is not continuous and not comprehensive and not team-based? That's going to require national discussions and then state discussions of how to finance it. Similar to when we responded to a pandemic, guess what? We eliminated some of the barriers to say we're going to improve access to care. That's the kind of shift that we're going to need to be able to see if a birthing center meets the qualifications for the standardization of care, and we know how to escalate care when surgical intervention is needed. Then you will have a system that functions. Right now, we don't have that.
I'd like to slightly shift gears here in our last few minutes and ask you all just to give me your thoughts on the impact of Dobbs on the maternal health crisis. I know it's a big thing on so many people's minds, and if you guys could each just give us your thoughts in a few minutes.
So I'll go first. I think that I think that to the extent that it's there's a whole lot of issues in terms of the intersection of race in the abortion discourse, and the disproportionate impact that it will have on Black women, likely because of disparities in abortion rates in general, and also longstanding issues regarding equitable access to abortion care. For example, we have the Hyde Amendment, which still bans federal funds from covering abortion care. And so there's intentional discrimination coming out of the federal government regarding making sure that, poor women can have access to this. In terms of the actual impact, to the extent that it's causing a lot of providers of abortion to be laboring under anxiety and a fear of criminal persecution or prosecution, and a lot of uncertainty in terms of these laws that are really vague in terms of what would constitute a triggering situation for you to actually provide abortion, like in Texas. So do providers need to wait until somebody's on the brink of death to or actually provide an abortion? And so I think that there's a lot of that that's happening, and pushing providers out of these states as well. If they're burnt out, they're gonna, some people are leaving the states, and these are the states that can't afford to lose more maternity care providers. And so it's going to be an indirect contributor to the maternity care deserts that we've seen that somebody mentioned in the chat. And that already, it's like throwing gasoline on fire, so to speak, because a lot of these states that are cracking down on abortion rights don't have the necessary care to help women successfully go through pregnancy. And so I'll end there.
I'm not actually going to answer the question. I'm going to ask a question of Colleen, because I think I just recently saw that there were 5 women in the state of Texas who are actually suing the state because they were forced to wait. In one woman's case, it was until sepsis had set in before they were going to be able to give her an abortion. Did I get that right? It's 5, and this is the first time that happened.
Yeah, it's definitely what's happening now in terms of providers, even just like being afraid to mention the word abortion and talking in code and so just it's definitely creating, and it's intentionally the way that the laws, some of these laws are drafted intentionally vague to create all of this chaos and confusion at the provider patient level. And so I think that it's certainly going to be aggravating all of these health issues.
Mm-hmm, mm-hmm.
Yeah, I would agree with my colleagues. And the other, it goes to the heart of consent and ethical position, autonomy of your own body. So I think, again, our anticipation is, and it's unfortunate we need to see the result to see, but we anticipate that, in fact, it will have a detrimental effect on autonomy, on agency, and maternal mortality. Okay, and unfortunately, disparate outcomes as well, an aggravation of the health disparity ratio. So, that's not hopeful, but I think, again, conversations like this, I do want to thank the sponsors of this, and to root it in the bioethics department is wise, because these are ethical discussions in our profession. We must do good and not just no harm. And the discussions around our political systems that are not based on justice, I think, is what our conversation has been. So thank you.
Well, sadly, we are coming upon the hour here. This has been an incredible discussion. And I am going to now ask Sandra to close it up for us. Thank you all so much.
Yes, thank you. This has been an incredible discussion, and I'm truly inspired by our panelists' charge for all of us to embrace a justice lens and to consider our roles and the roles of our institutions in intervening on structural racism and alleviating human suffering. I want to also thank our Bioethics and Film Organizing Committee for their support in planning for this year's series, particularly Dunya Alami Nassif, Tiana Sipapur, David Lamb, and Shauna Benston, and to thank all of you, our wonderful audience, for your very thoughtful questions. The recording of this event will soon be posted on our division website, the Columbia Division of Ethics website. In addition to the resources that were mentioned in today's session, our team has compiled a bibliography of the resources related to this topic, and you will be able to find that bibliography on our website as well. We look forward to coming together again in the fall of the new academic year for our next Bioethics and Film event. That will feature the film The Silent Child. Please subscribe to our mailing list to stay up to date on details that will be forthcoming. We also want to invite you to register for our next Ethics Grand Rounds, which is entitled Medicalizing and Criminalizing Mental Health, with speakers Leah Pope, Kimberly Sue, Faye Owens, and I'll be moderating the event. That event will take place on May 2nd at 12 noon Eastern, and there is a link, I believe, in the chat to register for that event. Also, you might consider joining us for the next LC Friday Forum. LC stands for the Ethical, Legal, and Social Implications of Genetics Research. The forum that is occurring on April 14th at 12 noon Eastern is entitled Visual Storytelling in LC Research. Again, the link is in the chat. To receive information on these events, and there are many more, please subscribe to our Division of Ethics newsletter. And then finally, you will receive a post-event survey, and I really encourage you to complete this as our organizing committees take these comments from you and suggestions very seriously. Past responses have informed how we've improved this program and how we might bring new topics of relevance to you. So please do fill that out. Thank you so much for all who have joined us. Again, a big thank you to our panelists and our moderator. I wish you all a great week, and please do take good care.